presentation as if we are speaking to a group of primary care physicians, although I do talk to nursing home also my practice that I run. My name is Andy Mencia. I'm a fellowship trained geriatrician practicing in Fort Lauderdale. And today we want to talk about the role of the cholinergic therapy in the treatment of Alzheimer's disease, which, as all of you know, is the major type of dementia that we deal with on a day-by-day practice. And I want to make the presentation so that you come out of here feeling comfortable in making the diagnosis of Alzheimer's disease. But more important than that, for all of you to understand that Alzheimer's disease is a condition that, if diagnosed early in the clinic and treated properly, you can bring a lot of benefit and happiness to the patient and the family. And the diagnosis is basically, as this slide is doing an interviewing your patient and looking for key points that will make you think of a memory impairment. For you to understand, especially in moderate type of dementia, that the caregiver becomes an important part of diagnosis dementia and treating and following of the patient. So the caregiver should not be ignored; it should be integrated into the formula. The office-based clinical assessment will need a comprehensive physical examination. In that physical examination, basically you are looking for any gross abnormality, any gait instability, incontinence, thing that will make you think of the differential diagnosis of Alzheimer's disease. You want to do a brief neurological exam and a mental status evaluation. In my office, I train my staff so that they are able to do a mini mental exam, and you don't have to take your own time to do that, especially some of you that have to deal with a lot of HMO and you don't have time. So we want to make sure that we make the talk to you so that it's realistic and make you see that this is something that you can do and you can follow up without losing your patient to either a nursing home or to other physicians because the family feel that the patient is not being treated properly. The office-based clinical assessment should also include a complete laboratory workup, and usually that will be the CBC, a chemistry profile, a full chemistry panel, the RPR to rule out any syphilis, liver function test, do a thyroid function test to rule out any thyroid disease that can mimic Alzheimer's disease or can mimic functional decline. Vitamin deficiency, like B12 deficiency, that is what we call the quote-unquote reversal of dementia. And when indicated, it's important to obtain an imaging study. And I have seen in my private practice patients that have been diagnosed and seen by including neurologists and several practitioners that the patient had jumped from one to the other one looking for answers. I have seen a lot of normal pressure hydrocephalus, and as all of you know, it's one of those conditions that you become a hero. You treat the patient reverses, and significant improvement you see most of the time. Not always, but most of the time. So you want to look for those kind of things. The last thing that you want to do is be burnout for the patient that you are treating that has a metastasis to the brain, and you are treating as an Alzheimer's disease. And when indicated, if the diagnosis is not clear-cut, you want to do the neuropsychological testing. And in my practice, I try to do all of those patients with mild dementia, if possible, do a baseline neuropsychological testing And then I follow with a mini mental exam and the other baseline tests that I do in my office. And every year or every 2 years, I repeat the neuropsychological testing to see which way we're going and what kind of improvement we are making in the patient. Dementia is no Alzheimer's disease only. And there is a misconception out there in the community, and it should be all of us responsibility to inform your patient and the family that there are different types of dementias. Yes, Alzheimer's disease is the major one. It constitutes 65 to 70% of all the type of dementia. But you have also the vascular type of dementia, the multi-part dementia, that constitute 5%. And then you have that one that overlap with Alzheimer's disease, and that constitutes about 10%. And then you have Alzheimer's disease dementia with that overlap with Lewy body dementia. And those are the patients that present with a lot of hallucination. They see animals, they see smoke, little people. They can become very agitated, and they constitute about 5%. And then you have the other type of dementia that you would tend to lean more to the more specialized, to other specialists to handle, such as frontal lobe dementia, Creutzfeldt-Jakob disease type of dementia, Pick disease, and other type of dementia. But the bulk of the dementia, all of us, you and I, will be seeing every day in our office. And this is the one that you should be concerned about. What are the diagnosis criteria for Alzheimer's disease? Basically, it's a development of multiple cognitive deficit, and the cognitive deficit is the cognitive deficit in Alzheimer's disease is very characteristic. That is slow onset and is progressive. It's nothing approved. So if you see a person that ends up in the hospital for whatever reason and has an approved cognitive deficit, that is not dementia. You're dealing with delirium, you're dealing with something else that you need to dig into. And the cognitive deficit will manifest both with memory impairment and apraxia or agnosia, aphasia. So the patient with a memory impairment usually is what we call first to come, last to go. They will lose more of the short-term memory. They remember what happened 20 years ago, but they forgot what they had for breakfast before they came to see you, or if they have breakfast or not. And this is very important for you as primary care physician, because what we see in my practice as a geriatrician is a lot of polypharmacy. And the reason that you see a lot of polypharmacy is because you give a patient a drug for high blood pressure, and you check the blood pressure on the patient. The blood pressure is still high. You maximize the dose. Then you give a second drug to the patient. You might be giving 2 or 3 drugs to a patient that the drugs are staying home, and the patient is not taking them all of the time because of the impairment in memory. The person just forget to take the medication. The more drug you give the patient, the more complex the care becomes, and therefore now you have a patient that is in polypharmacy, and the person may not even taking the drug, and the person may one day or another, or God forbid, one of the family members come by the house and say, "Oh my God, you're supposed to take 4 pills for blood pressure, and you're not taking any of them." The patient take all 4 pills, and the patient will meet you at the emergency room with orthostatic hypotension or a fractured hip or something like that, because now we realize that we have over-medicated the patient. The patient from the beginning was not taking the pills. So memory impairment can be very detrimental to the patient, and I hope you can see the importance of us keeping track of this. The patient may forget words in their conversation, and you can pick this up when you are talking to the patient. I'm taking that thing that you gave me, and I came with the person that is outside. That person, is his daughter, and the person is forgetting. That might give you an idea I forgot those things that I used to, so I can hear you better. So if the person has word finding difficulty and is showing you signs and symptoms of a cognitive deficit, it should give you a hint that this person needs a mini mental exam, that you should go beyond and investigate. Then there is also executive functional decline. Now, I have this problem when I get called at 2 o'clock in the morning with a patient with acute myocardial infarction that they're going to do TPN, and I might put on my pants before I put on my underwear. But that doesn't happen to me every day. The demented patient doesn't do that. They do it every day. They put on their shirt before they put on their undershirt, or they put on their pants, and then they put on their diapers or their underwear. So there is an executive functional decline. Also, there's significant impairment in social and occupational function on the patient. So it's a gradual onset and it's progressive. And that's the key that should warn you that you're dealing with most likely Alzheimer's disease. There are other conditions, as I mentioned to you earlier, that you should always keep in mind. Parkinson's disease, normal pressure hydrocephalus, metastasis cancer to the brain, and systemic condition that also can mimic dementia. Hypothyroidism, vitamin B12 deficiency, person with substance-induced condition, alcoholism, etc. And we need to always, before we start patient on any medication, make sure you rule this out before you can go on. Remember what I told you about delirium. You do not want to make the diagnosis in a patient that is going through an acute delirium state. And you want the disturbance not to be accounted by anything like schizophrenia or any other condition from Axis 1. This is an old picture, and it had been on most medical books since Alzheimer's first came up with a diagnosis in 1907. Basically, what we see is a normal brain that will weigh around 1,500 grams, and this is the brain of a patient with Alzheimer's disease, and this one will weigh around 800 to 900 grams. And when we do the microscopic analysis, you see the amyloid plaques that are formed, and the other characteristic, the other thing that we see in Alzheimer's disease is the neurofibrillary tangle that form in the axon. The cholinesterase activity in the brain of the Alzheimer's disease, we're looking here at the cortex and the hippocampus, basically. And as you can see here, the acetylcholinesterase decreases in the cortex as well as the hippocampus, and in turn the butyrylcholinesterase increases or in both, and these are areas that are important in cognition in the brain. This slide is depicting the correlation between cholinesterase inhibition and a new drug that is being used now for the treatment of Alzheimer's disease. This is the new kick on the block, rivastigmine or Exelon. And here we see the correlation with the cognitive changes. And as you can see in the slide, this is the area under the curve. And by inhibiting both butyrylcholinesterase activity, all of this area improve. And it does not affect that much acetylcholinesterase activity. And when it comes to the treatment of Alzheimer's disease with a cholinesterase inhibitor, what we are trying to depict in this slide basically is the drugs that are available up to today and the ones that are about to come out, to give you an idea of a head-to-head comparison of how what we know about them. Ticagrelor is the Godfather is one of the first drugs that came out. It doesn't have brain selectivity, different from the other three. It is reversible. It does affect the inhibition of acetylcholinesterase and butyrylcholinesterase. And it does it also as Exelon. Aricept is brain selective, but Exelon in turn is also brain selective, but is brain region has brain region selectivity, meaning that it tends to act very selective in the hippocampus and the cortex. In some of the studies they have done. Like I mentioned, they are all reversible. When it comes to the dosing, titrate is one that usually you give four times a day. Aricept is a once a day dosing. Rivastigmine is twice a day. One of the things that you want to keep in mind with this medication that you might want to give it with food, and you have to keep in mind that even with food, it might interfere with the absorption of the medication, but it will minimize the side effect of the drug. Galantamine, we don't know too much about it. It's a medication that is being submitted for approval to the FDA. Drug-to-drug interaction is important, especially in the elderly patients that are taking many medications. And one of the good things about Exelon is that it does not have any drug interaction because it does not get metabolized by the P450 like the other medication. As far as the plasma half-life, Aricept has 70-hour effects. Exelon has approximately 1 hour plasma half-life. It does not say anything to us about what is the brain half-life, but it's important when you are trying to make switch from one medication to the other one. The elimination of the drug, the pathway that Aricept uses is the liver, and Exelon uses the kidney, where galantamine uses both of them in the 50-50 portion. This is just to remind me to tell you that when you are using any of this medication, that you want to titrate the patient, but you want to do it slowly. What you are doing, what we're seeing here is the adverse effect of the drug when you titrate a 1 week period versus 2 week period. It's a significant decline. So one of the rules in geriatric medicine is that we want to start slow, and then we want to go, but we have to go. Don't stay at a lower dose. Looking at the impairment of activity of daily living in patients with Alzheimer's disease, looking at the global, looking at mild, moderate, and severe Alzheimer's disease, and as you can see, there is less impairment in all across the board, in all three levels, by treating the patient. I'm trying to rush now.
Yeah, fine. You're in good shape.
Okay. Again, this is looking at rivastigmine on the effect of activity of daily living. And as you can see, using the 6 to 12 milligram, there is a significant slowdown of the decline on the ADL. And this is important to all of us because this is what the family is looking for. They don't care what the mini-mentor score is or what any of the other tests that you might want to do in your office. They want to know the bottom line is what can that patient do at home, and what medication can you give to help this patient improve and stay at home and not at a nursing home in a premature time. This is the effect of rivastigmine on antipsychotic use, because rivastigmine is one of those medications different from the other that can affect behavior. As you can see here, there was a 30% reduction of antipsychotic in this open label trial in a nursing home setting. In 12, almost 13% of the patient had a reduction of antipsychotic medication. And if any of you go to nursing home like I do, there are many rules and regulations that are involved in nursing home, and it might be one of the institutions that is more regulated than any other institution that care for the community out there. And one of the things that when those nursing homes get inspected, they are looking at how many drugs the patient are using. So with one medication like this one that will help us reduce the amount of medication, the number of drugs that patients are using in a nursing home. This is looking at the effect of Aricept on cognition, and as you can see with the 10 milligram, there is improving cognition with Aricept, as well as with the 5 milligram, and this is compared to a placebo arm of the study. And then this, and the endpoint was 26 weeks. And then this is the washout period. But look what happened when the medications are discontinued.
2 minutes.
And this is important when you're switching the patient from one medication to another one, that you don't want to allow for this washout period, because then you're going to have a hard time starting all over again. And now this is the effect of Exelon on the same parameter on cognition. And as you can see, with the 6 to 12 milligrams, a significant improvement, and with the 1 to 4 milligrams. So it's dose related. And this is the long-term effect of donepezil on cognition. And this is for rivastigmine, up to 52 weeks, looking at cognition. And again, you see the same, the significant improvement. So in conclusion, Alzheimer's disease is a primary diagnosis it's a diagnosis of inclusion, not of exclusion, like we used to think. And it's made clinically, it's made by you and me. There are three key symptomatic domains: activity of daily living, behavior, and cognition that we should keep an eye on and try to follow in our patient with Alzheimer's disease. Keep in mind the adverse effect of a cholinesterase inhibitor, and that they are generally dose-related, so don't get scared when those side effects show up. Just go ahead and reduce the dose and follow your patient. Reassure the family. They will not discontinue the medication because the patient is saying so. It's because the family is scared. So if you reassure the family, reduce the dose, you might be able to keep the patient with the medication. Taclin and donepezil show positive effect in some of the domain in patients with mild to moderate dementia, where rivastigmine show positive in all three domains that I just mentioned to you, in all stages of Alzheimer's disease. Remember that early therapeutic intervention is the key of